Welcome to part 3 of this lecture series. You will recall that one of the desirable attributes of a good clinical practice guideline is that it makes use of the best evidence. We will therefore spend some time looking at how to assess evidence. By the end of this section, you should be able to define and distinguish between quality of evidence and strength of recommendation. You should also be able to explain the use of grades of recommendation, assessment, development, and evaluation in evaluating evidence. There is a need to identify evidence because the recommendations of a clinical practice guideline must be based on the best available evidence. Looking for the best evidence involves a systematic search of all relevant sources. These include searching for all systematic reviews and meta-analyses that deal with a question of interest, all randomized controlled trials that have addressed this question, as well as all related observational studies. Also, any previous practice guidelines that have addressed the issue at stake. Where no evidence exists, expert opinion or consensus may be used, but this must be clearly stated. Data are extracted from the relevant studies on the benefits, the harms, and where applicable, the cost of the interventions of interest. After locating the evidence, we need to summarize it. The summarized evidence is categorized to reflect its susceptibility to bias, and therefore the quality of evidence. The quality of evidence is defined as the extent to which one can be confident that an estimate of effect is correct. In healthcare decision-making, stakeholders are not only interested in the best estimate of the benefits and harms of an intervention, but also in the confidence we can place on this estimate. Quality of evidence has traditionally been dependent on the research designed with randomized controlled trials being ranked higher than observational studies. A number of categorization schemes exist, primarily based on study design. Quality has frequently been expressed by assigning a score. Some categorization schemes, for example that of the American Academy of Pediatrics, use A, B, C, or D, while the National Institute for Health and Care Excellence, NICE, of the United Kingdom uses 1A, 1B, 2, 3, and 4. This slide shows some examples of the hierarchy of evidence from the American Academy of Pediatrics and the National Institute of Health and Care Excellence of the United Kingdom. They both illustrate that randomized controlled trials are regarded as providing higher quality evidence than observational studies. If you like, please take a moment to review these categories. Now let's look at the strength of recommendation. Guidelines and recommendations prescribe certain courses of action. Healthcare providers must be able to help their patients make informed decisions about such recommendations, taking into consideration the patient's values and preferences. Such recommendations must indicate whether the evidence is of high quality and whether benefits clearly outweigh harms, or if there is a close or uncertain balance. A simple, transparent grading of recommendations can help convey this information. The strength of a recommendation is defined as the extent to which one can be confident that the desirable consequences of an intervention outweigh its undesirable consequences. High-quality evidence doesn't necessarily imply a strong recommendation. For example, in instances where harms outweigh the benefits. On the contrary, strong recommendations can come from low-quality evidence. For example, the strong recommendation to use acetaminophen instead of aspirin in febrile children did not come from strong evidence. Some observational studies, and remember, observational studies are regarded as providing lower quality evidence, had observed the association of Reye's syndrome with the use of aspirin in children with fever. Acetaminophen has about the same antipyretic effect in children, but does not have any association with Reye's syndrome. Therefore, it was thought better to avoid aspirin entirely, even though the evidence was not as strong. We have discussed quality of evidence and strength of recommendations. Different groups or organizations that develop clinical practice guidelines have specific ways of categorizing the quality of evidence and the strength of the recommendation. We are going to examine in more detail the scheme used by the Grades of Recommendation, Assessment, Development, and Evaluation Working Group, GRADE. The GRADE system is used by a number of organizations worldwide, such as the World Health Organization, the Cochrane Collaboration, and multiple professional associations. Let's examine quality of evidence under the GRADE system. GRADE classifies the quality of evidence in one of 4 levels: high, moderate, low, and very low. Some organizations combine the low and very low categories. High-quality evidence means we are very confident that further research is not likely to change the estimate of the effect. Moderate quality means that further research is likely to have an important impact on our confidence in the estimate of the effect and may change this estimate. Low-quality evidence means that further research is likely to change the effect estimate. Very low-quality evidence means we are very uncertain about the estimate of the effect. Evidence derived from randomized controlled trials is regarded as high-quality evidence. However, our confidence in them may be decreased to a lower level, such as moderate or even low, by certain factors, including risk of bias, inconsistency of results, indirectness of evidence, such as using surrogates in place of clinical outcomes, imprecision, reporting bias. Evidence from observational studies, such as case control and cohort studies, are considered to be low quality to begin with. However, certain factors may lead to the evidence being ranked higher to moderate or even high. Such factors include a very large magnitude of the treatment effect, evidence of dose-response relationship, or if all plausible biases would decrease the magnitude of an apparent treatment effect. Strength of recommendation. You will recall that we defined strength of recommendation as the extent to which one can be confident that the desirable consequences of an intervention outweigh its undesirable consequences. We also mentioned that a high-quality evidence does not necessarily translate into a strong recommendation. The GRADE system classifies the strength of recommendations into either strong or weak. Other terms for weak recommendation include conditional, discretionary, or qualified. As we said, strength of recommendation depends not only on the quality of evidence, but also on the balance of desirable versus undesirable outcomes and the values and preferences of the consumers, patients, or any users of the guideline. This is the end of this section, and we will break for a short quiz.